in medicine. I think this topic is I don't want to steal any thunder. We're honored today to have Dr. Ted Marcy join us, a retired pulmonary and critical care physician, professor at the professor of medicine at the University of Vermont for almost 20 years. When I first met this individual, we had a conversation on Zoom, and he didn't even know me. He took time out of his busy life and his busy schedule just to sit down and share his experiences in medicine and share his experience in this journey towards equity and liberty and justice for all. As for the 20 years that he chaired the University of Vermont's Human Research Ethics Committee in behavior and social sciences. This is what's known as an IRB. I mean, a number of research protocols that were developed about research around just how to treat humans. But you know, when you're a Stanford undergrad and Yale School of Medicine grad, I think you bring a certain wit and certain people skills, but also leadership skills to how to navigate this healthcare system. And as I mentioned, to make sure it has liberty and justice for all. There's no way I could read his entire CV. It would take us about 30 minutes to go through that. But Dr. Marcy, if I can just turn over to you. I mean, I can go on and on with the accolades. I'm just saying thank you for taking time to be a part of our team, our village, our community, and to fight for justice. So I'll turn it over to you. I hope that did some just a little bit of sharing your background and experience.
Well, thank you, Kamal. I appreciate that. So very briefly, I'm from Burlington, Vermont, and I know of a long talk through the New England Annual Conferences for the United Methodist Church, the conference in June that those of you who heard McAvoy and Joanne Huss 2 weeks ago described. That's how I learned of a long talk and first met Kyle and Kamal. And then I did the 21-day activation and had the one-to-one that Kamal nicely described. And he asked if I could do a talk on relationship of medicine and racism. Um, Before I start, I'd really be interested in a show of hands. Who among you are a healthcare professional? And by that, I mean a physician, nurse, physical therapist, clinical social worker in a clinic. Um, all right. And there are a lot of people, so but I gather that at least a portion of you are that. The other identity that I'm interested in is who among you identifies either as a black or as a member of another minority racial group as our society defines it. Okay, great. Um, I have about 20 slides, and I'm estimating it will take maybe 30 to 40 minutes to go through those. I want to leave plenty of time because I want you to share your lived experience with this, whether you're a healthcare professional or a member of a minority racial group as it's defined in this society. So, Kamal, if you could start the slides, that'd be great. Okay, so Kamala has already stated what this slide says. I am a retired professor of medicine at the University of Vermont, Leonard College of Medicine, and had worked as a pulmonary and critical care physician. Sort of mid-career, I got very interested in tobacco control and went back to school to get a master's of public health. And got very active in the state of Vermont of building their tobacco control program and evaluating it. But because I was doing research on the behavior of physicians, I got roped into being a member of the Institutional Review Board at the University of Vermont, um, looking at whether or not human whether protocols involving human research participants were adhering to the regulations, the federal regulations on human research. And those came out of the exposure of the Tuskegee Syphilis Study in 1972. A blatant episode of medical racism. All right. With that as a background, next slide. I'm showing you what my usual medical note looked like through my career. Medicine is, or at least should be, a team sport involving a collaboration among healthcare professionals to provide care to individual patients. And for the team to function, you have to communicate uh, in a succinct yet informative way the patient's health history, their story. And that's what a medical note did. And there's a structure to it. You would say a brief patient identification, their chief complaint, their history of present illness, their past medical history, family history, social history, physical exam, lab findings, assessment, and plan, or something similar to that. Now, in the hypothetical note that was representative of how I would write my notes and how everybody else seemed to write their notes was my patient identification says a 30-year-old black male bank clerk who presents with a chief complaint of shortness of breath for 2 weeks. Now, I hope you believe that my stating that this person in front of me is 30 years old is important. I mean, the list of possible causes of shortness of breath in a 30-year-old is very different from that in an 80-year-old. And age is measurable. In the same way, whether the person in front of me is biologically male or female also is important. There are innate biological differences between males and females. I mean, it's important to know whether the person in front of you has a uterus or a prostate, different hormone milieu. If the person was identified as a transgender male, I would state that because that would communicate that the person was born biologically female and underwent some form of transition therapy to become to be identify as a transgender male. But what do I mean by black? I mean, how did I define that? Did I ask whether one or more of their grandparents was black? I mean, that's how blacks used to be identified in some southern states. Um, did I measure blackness? I mean, is Barack Obama half black, half white? Um, did I ask them to identify themselves? I generally did not. I sort of did it based on appearance. Um, so my stating that the person is black doesn't convey the same level of precision as age and biological sex. And so, why did I do that? There, I, I'm, I'm, I'm naming myself as someone who participated in this sort of race-based approach to medical care. So, Kamal, the next slide. Um, if you're looking for an outline for my talk, this is it. Um, Biologically, there is only one race within our species of Homo sapiens. If you look at DNA samples from humans across the world, you see that there's a continuum of genetic variation, but there's no place where you can draw a line and say there's a major difference on one side of the line from the other. So if one defines race as a distinct, discrete, identifiable population, then there's no such thing as race among our species of Homo sapiens. Instead, race and ethnicity are social constructs. We've defined them socially based on appearances and where people live. And as such, these designations do not generally provide a direct causal explanation for observed health conditions and outcomes. And I'm going to try to illustrate that. However, because of structural racism, these social categories do correlate with exposure to very important and very powerful social determinants of health, poverty, lack of health resources, food insecurity, and others that we'll get into. So we can't be race blind. We should not be race based. What I'm going to get to is the idea that we need to be race conscious when we practice medicine. Next slide. All right. So, is sickle cell anemia a black disease? Okay, so sickle cell anemia is a single gene disorder and occurs when an individual has two genes coding for a portion of the protein hemoglobin with a mutation that's designated hemoglobin S. And when you have two copies of this gene, the hemoglobin causes the red cells to deform, as you can sort of see in that figure with the arrows pointing to it. And what happens when that deformation occurs is that the blood cells get destroyed and anemia occurs. There's also occlusion of the blood vessels, causing end organ damage, lots of pain. It's a terrible disease. And I took care of a number of patients with sickle cell anemia in Rochester, New York during my residency. You'd think that evolution would get rid of this mutation. But as it turns out, if you have one copy of this hemoglobin S gene, it confers a significant survival advantage in areas where malaria is prevalent or endemic. And malaria is caused by a parasite, Plasmodium, spread by mosquitoes. It is estimated to cause over 260 million cases a year and over 500,000 deaths. But it's within certain geographic areas. So having one of these genes in those areas reduces the risk of severe malaria by 90% and hospital admission by 60%. So that survival advantage preserves and actually increases the gene frequency in areas where malaria is prevalent. So next slide. So this image taken from the resource that you see there, at the top in red, it shows areas where there's a higher frequency of this hemoglobin S gene in the population. And you can see that it is centered a lot in sub-Saharan Africa. And that is where a lot of malaria is present. That's what is in the green graph. But if you look carefully, there's also a fairly large amount of hemoglobin S in Greece, in the Middle East, and even in the subcontinent of India. So, sickle cell diseases occur in higher frequency among those populations. Um, um, you so a black individual from South Africa, down low, where there isn't much malaria, are not likely to have this mutation. And conversely, individuals who are identified as white from Greece, the Mediterranean areas, or Asians from India are potential carriers of this mutation and may have sickle cell disease. So sickle cell disease is not exclusively a black disease. It's more nuanced than that. Next slide. Another genetic disease is cystic fibrosis, again, a single gene mutation. And this is thought of as a white disease. In fact, it is characterized as the most common lethal genetic disease in white populations. And it's due to a single gene inherited disorder of the cystic fibrosis transmembrane transport regulatory protein. And again, a pair of genes leads to mutations. A pair of these mutations leads to severe multi-organ disease, affecting lungs, digestive system, and digestive tract, and other systems. The outcomes of this disease have improved dramatically. When I started medical school, the median survival was around 20 years. Nowadays, it's close to 70 years because of advances in medical therapy. But is this exclusively a white disease? Next slide. No, it's not. It's more common in the white population, but it's still present in other race categories. Even in lily white Vermont, which has a almost 95% white population, I took care of a black individual with cystic fibrosis. So next slide. If you attach an innate biological risk to an individual because of their socially identified race, you're going to increase the likelihood that you're going to make a misdiagnosis. You're going to exclude the possibility of a disease in a racial group where you don't think it can even occur. The incidence of disease, in other words, is not black and white. It's more nuanced. There's more information that you need than how that person is being socially identified. Next slide. Um, Beyond that, there are some other examples of race-based medicine. As a pulmonary physician, I would read and interpret pulmonary function tests. You may know of spirometry, where you take a deep breath in, blow out as hard as you can, measure the total amount of air you get out and the amount of air you get out in 1 second. And then you compare it to what you would expect in an individual of the same age and sex and height. But we then would apply a race correction to those who are Black or Hispanic, reducing the normal value expected by 15%. And what that might mean then is that a white individual may be interpreted to have an abnormal result, but the same results in a Black individual will be considered normal. And that might lead to differences in treatment. When actually the data supporting that race correction is fairly thin. Perhaps more egregiously is the use of race corrections in estimates of kidney function. So for those of you who are not medical, the kidneys clear waste products from the blood. We want to measure how well the kidneys are functioning in terms of determining if additional therapies are required. A shorthand for that is the glomerular filtration rate, or GFR. To accurately measure it, you have to do a 24-hour urine collection, but that's cumbersome to do, expensive, and such. You can estimate the kidney function by just looking at the level of a waste product that's cleared by the kidney called creatinine. Creatinine is created from muscle function and metabolism. The higher the level of the creatinine, the lower the function of the kidney. And we can estimate GFR from that serum creatinine concentration. Next slide, Kamal. So here's an online GFR calculator for adults that's available now online. I don't think my URL is showing up, but and I'm not sure I wanted to distribute this, but here we take a person whose serum creatinine is 3.5, age is 50, and is male. And if I put not Black, I get a GFR of 18.6. In this case, lower is worse. But if I click on Black, I get a different result of 22.6, a better result. It's the same serum creatinine, same age, same sex. What's the impact of this? Well, the person who's not Black with the estimated lower kidney function is more likely to be put on a transplant list. So this type of race correction discriminates against Blacks getting on a kidney transplant list. Fortunately, this race correction is no longer considered in kidney transplant centers in the US, but that is only as of 2022. So I hope I've made it clear that this kind of race correction led to discrimination against Blacks getting kidney transplants because for reasons that are not well established or verified, a correction was applied based on the identification of the person's race. Next slide. Some additional examples. Physicians would tend to use diuretics in Blacks as opposed to a different type of blood pressure measurement, blood pressure medication in whites, based on a small difference between response in Blacks versus whites in one study. The difference was like 7%. The term we use for that is that it's statistically significant, but not clinically significant. And yet people were basing treatments on group responses rather than on the individual in front of them. Maybe most importantly, is that using race-based sort of linking of diseases to it pathologizes race. If you know that more blacks have diabetes, you just sort of say, well, that's what blacks tend to get. And that is an inappropriate assumption to make without appropriate context. Race is a proxy for the real underlying causal factors. And I hope to bring that out in the next several slides. So next slide, Kamal. Um, what are the true drivers of health outcomes? Well, because of structural racism, people identified as Black have been treated differently, experience life differently, and have different levels of access to life and health affirming resources and opportunities. And this an increased exposure to adverse social determinants of health explains much of the disparities in health outcomes in Black versus white populations. Next slide. So we're going to look specifically at type 2 diabetes mellitus. This is a disorder of glucose metabolism. Um, it is the seventh leading cause of death in the United States. It causes both increased mortality, but also a lot of morbidity, heart disease, kidney disease, peripheral vascular disease with amputations, loss of vision. The list goes on. It basically sucks. If you look at blacks versus whites, and I put that in quotations because they're socially identified, the prevalence amongst blacks is about a third greater than in whites, 18% versus 13%. Among those who have diabetes, we can look at how well the diabetes is controlled with the different measures. And we can control diabetes with diet, behavior, and medications. Almost 21% of those who are white with type 2 diabetes have good control, as opposed to only 12.5% of blacks. And that results in the fact that the hospitalization rate for blacks with type 2 diabetes is almost 3 times greater. And the age-adjusted death rate is more than twice that of whites. Why is this? Is this just inherent in being black, or is there a different reason? Next slide. Well, very powerful determinants of health outcomes include socioeconomic status, and that is measured by education, occupational level, and income. But you can just sort of think of it, who's doing well and who's not. And there is a continuum of socioeconomic status. And what I learned in public health school is that this is an extraordinarily powerful determinant of health outcomes. And it probably works through neighborhood environments, food environment, access to healthcare, social contacts, lots of things. Next slide. If we look at SES, socioeconomic status, and the prevalence of diabetes, all comers, you're much more likely to have diabetes if you have less than a high school education, regardless of your identified race. Also, if you look at income, and there's a typo, it should say income in comparison to federal poverty level. The federal poverty level income is about $15,000 per individual or $32,000 for a family of 4. If you earn less than that, the prevalence of diabetes is 14%, compared to that of people who are making much more money. 500% of federal poverty level would be 150,000 or more. their prevalence of diabetes is much less. Um, and you can imagine that what's happening is that Black individuals are disproportionately members of a lower socioeconomic status. Um, Next slide. And and the problem of that is that it is cyclical and intergenerational. So if you don't have a very good education, you're not going to get a high level occupation, and thus your income is going to be lower, and that's going to determine where you can live, and that's going to impact your children's level of education and their occupational level. I think one of the stories in Jeffrey Robinson's long talk that really stuck with me was how cunning and deceptive his father had to be to get him, Jeffrey, into an area where he could get a good education. It is tough once you're in a low SES situation to get out of it. Though Jeffrey's family's issues were issues that my family never faced. Next slide. So how does this fit with structural racism? Well, if we look directly at education, there were for a long time U.S. state anti-literacy laws that prevented or prohibited teaching blacks how to read. We all know about segregation laws and the impact on access to quality public schools. And I think there still is disproportionate spending between white versus non-white school districts. In terms of occupation, again, Jim Crow and segregation laws that restricted types of employment for blacks. And in terms of income and wealth, there are racial pay inequities, and not to mention centuries of unpaid labor on wealth non-accumulation. Um, and this is far from being comprehensive. I'm just showing examples of how structural racism leads to a disproportionate number of individuals identified as Black as having low SES, and then that driving their health outcomes. Um, Next slide. So that translates into what we see in terms of diabetes prevalence by race and ethnicity. A white non-Hispanic population has a lower prevalence of diabetes. These minority race and ethnicity groups have higher. Um, and so it's important for us to recognize how this translates into the kind of health outcomes we perceive. Okay, so how do we get to a race conscious approach to medical care? Um, the first thing, and probably easiest, and one that I never had the opportunity of doing, is to avoid including race in the chief complaint or medical history narrative, and instead elaborate in the social history at a much more granular level. So, come on, bring up my race conscious medical note. So here I just identify the patient in front of me as a 30-year-old male bank clerk with shortness of breath for 2 weeks. But in the social history, I provide more granular detail. He's a new American who identifies as Black, who immigrated 3 years ago from South Africa after he completed college. He's employed full time. He's married. He owns his own home. Now, I'm going to ask you you don't say anything, but how does that picture equate with the initial image you got from my original medical note? And just sort of note that in your mind. Okay, what other things? Clearly, there's variations in genetics and exposures across a population, but you have to use care in applying group level assumptions or stereotypes onto individuals. They don't track carefully. Um, you may consider a disease more likely in one group based on appearance than another, but you should never exclude um, diseases that way. And you certainly should be very cautious, if ever, using race-based corrections to algorithms or normal values. We all have to explore the issues related to individual outcomes and this structural level racism and discrimination. Again, we can't be race blind because we have to be attentive to what the person in front of us may be experiencing in their life that has an impact on their health. And included in that is learning about the history and ongoing manifestations of racism in medicine. I told Kamal this before we started, but an aphorism that I have is the person who learns the most from a talk is the person who needs to prepare it and give it. And I've learned a great deal just preparing this talk. Um, and in my own mind, it's trying to uh, at this point convey this to the rest of you. Um, all right. I think that's the last of my slides, Kamal. Is that true? Yep. Okay. So let's see. I've left 27 minutes. I I I I know that as a white male in a high SES category, I am one of the most privileged people on this planet. And I can talk about the experiences that people identified as black may have, but I've never lived it. And so I want to make sure that I give space for those of you who have to comment. And so I will, at this point, be quiet.
Go ahead, Todd. I see it. Yeah, Todd. Um,
Yes, the question I have is why aren't doctors being trained to be race blind when it comes to the practice of medicine? Like, why is this system still perpetuated in our medical schools?
Um, well, one, I don't want them to be race blind for the reasons I said, because people who are identified by a certain race certainly experience life differently than someone like myself. But I think there is an effort and a trend to change this. There are a number of articles in the New England Journal that have highlighted the need to become race conscious as opposed to race based or even race blind. And I can certainly send through Kamal some of those references. What I've experienced in medicine is it takes time to change things, but things are changing more slowly than we, of course, would like. But they are changing, and some of the pressure comes from individuals within the medical community who are Black and recognize that this is a problem.
But do you believe it's overt in the sense that, like for stroke patients, they say people of color don't get the same drugs as majority folks in when they have a stroke?
Um, yes, I think there are health disparities in terms of how people are treated. Uh, the reasons for that are many, and I'm afraid that we all have implicit biases, which are involuntary and unconscious, but they're real nonetheless. And I think a lifetime uh, or that changes how we behave. Um, so I'm not denying that happens.
oh, yeah. Thank you for that. Claire, I see your hand, and Dr. Chambers.
Yeah, I think, as being a black woman over here in New Hampshire, I mean, I think part of the problem is we have a lack of minority doctors. And then I remember over 20, 25 years ago when I had a fibroid in my breast. And I remember asking the doctor, specific questions around Black women, and he could not answer that. And so I found that extremely frustrating. And I think what I witness a lot of times is that in the healthcare industry, they lump everybody together. And I think women could probably understand a lot better, right? In that um, the research always seems to be based on white men. And so when we have these issues, it's based on that gene spec versus everyone else. And so I don't know that there's enough research or experimentation or whatever that's being done for people of color and how those relationships show out when you go to the doctor. And for me personally, as I've gotten older, I make that a first one of my questions that I ask, is what is the comparison of me to a white woman when you're getting ready to treat me for something? And based on their answer is how I relate whether or not I want to stay with that doctor because I want them to be knowledgeable in who they're treating and what the differences are because we are different.
I, Let me comment as a researcher and member of study section and also from my IRB experience. There is much more of a requirement now that researchers include individuals of different racial categories because of what you stated, that if we base all of our decisions on research done in a white population, that does not necessarily get generalized to other individuals. Um, that was actually a problem with doing research in Vermont is that we have such a high white population, around almost 95%, that it was difficult to incorporate enough people of different races um, in the research. The NIH didn't accept that as an excuse. What they said is you need to collaborate with other researchers in other parts of the country that have higher proportions of different races in order to have an adequate representation of your research population. So I think there is a recognition of the need to include a large variety of people so that the results can be better generalized to someone like yourself.
Yeah. Well, thank you. I just want to add something really quickly before we go to our next person. It's interesting because I remember growing up and just living in Tuskegee, Alabama in the 70s, and you're talking about those syphilis experiments. And I remember my father, who is a physician, who was practicing medicine at the VA in Tuskegee, and just him ingraining in me from whether it was the music we listened to. Gil Scott Heron was a poet. He had a song, Tuskegee 626. If you just look that up, it talks about that experiment before the rest of the world knew about it. Here I am, this 3, 4, 5 year old kid who understands these experiments, and this is before anyone's even talking about it. And I'm realizing that I have to be cautious when I go to the doctor. I understand why my grandparents and my aunties and my uncles are hesitant, and still to this day, even as a family, if we have someone who goes to the hospital for treatment, there's multiple members of us who go. If there's physicians in our family, we go as support because we want to make sure they're receiving that top-notch care because often not, Black women have a higher tolerance for pain. We know with Black maternal mortality, we've had family members who had issues, and some of these modern day physicians in the 2000s and 20s, had there not been someone in their corner advocating, we could have lost that family member. So I think that spaces like this, and Dr. Marcy, I think the presentation and what you're sharing, this is how we turn the corner on this and this making strides in medicine is having conversations like this. I mean, you didn't have to take the time to do this. Our long talk community is looking to make and force this country to live up to the promise to liberty and justice for all and make sure that we're protected and we're safe. And I'll say this last point. In my father's medical books, I remember growing up looking at his medical books and seeing images. There were no Black images. just now, the medical literature and the medical schools, hopefully, I've seen new publications where you have people with different skin tones, but I saw all white examples on those pages as a child as I'm looking at these conditions and seeing. So I'll stop here. I'm sorry I jumped in between. Go ahead.
That's okay. I guess I'm up. Is that right, Kamal?
Kamal, Kamal.
Kamal? Yes. First of all, I want to say thank you to Dr. Ted Marcy for his presentation today, because it does bring forth a great awareness. Everything that Kamal has just said, I was going to say very similar to, from my experience and also a retired professional professor. I just want to say we do have to know our history from where we came to where we are. We also need to know the genetic screenings that are available. And when in doubt, don't hesitate to ask, because it's a learning process. You cannot shy away from asking questions. When in doubt, ask the question. I don't care if somebody says that question is too stupid. So what? You're going to learn from an answer, or if you don't get the answer you're looking for, then go to someone else to find the correct answers. That's so important. I do want to say, through my 55-year professional experience, racism has been prevalent in the medical field, and it still is. And what our government's doing right now is taking us backwards. We are going backwards. So it's more important that everybody do their homework, know your history, and then get your genetic screening and ask the appropriate questions. I don't care where you live in the United States or over in Europe. Ask the questions and know that information, because that's going to help you to make an informed decision with that practitioner that you're dealing with. And that's all I want to say at this point.
Thank you.
I really appreciate that. I think the last three people have talked about the importance of advocating for yourself, and I would emphasize that. Yes, ask the questions. I'm actually glad that the physician said, I don't know, because it's important to acknowledge when you don't know. What hopefully they say is, let me investigate that and get back to you. But yes, please advocate for yourself.
Thank you. Betty, I think you're off mute. Then I think Lynette, Mavis, and Vanessa, and then Lawrence. I don't know the order, but yeah.
Okay, my question or comment is simple, not simple, but straight. In Black maternal mortality, the issue of weathering, which is the persistence of the development of stress and its effect on cells, organs, et cetera, have contributed to our poor maternal mortality, regardless of socioeconomics. Have any studies been done more broadly on other disease that gets characterized as Black diseases, although they're not? Dr. Marcy.
Yeah, so I'm going to follow my counsel. I don't know the specific answer to that question. I do know that stress as a mediator of how low SES levels might cause poorer outcomes has been looked at. There's no one single explanation of that, how SES works so powerfully on health outcomes. But stress must be one of those. Ongoing stress in terms of blood pressure, diabetes, and I'm sure in terms of maternal outcomes as well.
Yeah, it's Dr. Geronimus has done a lot of studies on the fact that the maternal mortality that seems to be very high among Black women does not have any, that has very precious little to do with whether there's high socioeconomic or low, because the racial or racism stress is across the board. So It may be something to look at more broadly for other disease entities. Thank you.
Well, thank you.
I want to point out something. I know Lynette, I think you're next. Just in the chat, and it just said, "Thank you for sharing." I've had the experience with family members insisting to dress up to go to the doctor with hopes of getting better and fair treatment. I do it now. Doctors and nurses don't believe you. They minimize and dismiss your complaints and experiences and deny adequate medication treatment plans, and too often assume the worst. It's exhausting because wearing jewelry and fancy clothes does not protect us. It's sad that people just might get better treatment than showing up in jeans and sweatpants when you're sick. But so it just echoes because I do think about how I was taught and all the stuff I have to unlearn. Like, why do I have to present to say that I'm human? Because I'm black and I show up, if I have sweats on, why do I need to wear a suit or a collared shirt to even have a chance of being heard? But we know why, and that's why we're building this community to push back and change things. Lynette, I think Mavis, I'll just go across the screen. Lynette, Mavis, Vanessa, Lawrence. Yeah, that's how the order's on my screen.
Okay, thank you so much. Okay, so to the previous points in the last few minutes, Dr. Holston, Dr. Levy posted in here, and what Kamal just shared with us. And as Dr. Macy knows, right now, like we had just started, all the federal funding agencies had just started making a point to include people based on gender, race, ethnicity, just to study, because really the groups do have differences. And he's done an excellent job of pointing that out. But right now, it's important for you to know that the federal government is reversing, which has also been mentioned. And so now you can't technically include those things. They're trying to bury race again. They're trying to base ethnic differences. They're trying to base gender. They're trying to hide everything again. So this means that we have to rely more on private foundations for research funding. We also have to keep going with communities like this. But to your own care, it's so frustrating right now. But one thing that's been an excellent tool, I have chronic shingles, which I can't tell you how many doctors say, it doesn't even exist. And I'm like, I'm telling you, did you take pictures? Sure, I did. It's so frustrating. But so now AI gives you a tool where you have to learn to use it, practice with the chat bot. It's really fantastic. But you can go in there and you can talk to AI, and you have to be careful because the information it's receiving is biased. But it can get, if you are armed, you can go in to your doctor and say, this is what I know about this. Can you help me with this? Like, you have to have an honest conversation. If your doctor says, I don't know, I can look it up for you, that's probably good if they're willing to work with you and research. But more often than not, I'm going in and I'm finding, and I'm not a person of color, but I'm finding that my doctors have graduated 20 years ago. There's all these new tools for finding new information, and not one of them has cracked the book since they left. It's so frustrating because so much progress has been made and now it's being erased. So advocate for yourself, use the tools that you have if you have like access to them. For many people, that's not possible, but I guess I just implore everybody in the community to keep sharing that these things are real. We're not making them up, if you could.
Yes. No, and thank you for that. And I love that just as we have physicians who are practicing, from or who are not keeping up with current technology, I love the fact that we do have leaders on the other end who are researching, who are talking about race. I mean, when my father was talking about social determinants of health back in the 70s, they pushed him to the side. When he was talking about holistic health, they pushed him to the side. And so to see someone like Dr. Ted Marcy talking about it, and we have champions on the front lines, let's amplify that. And let's not forget that we have mass media and TV channels and social media, tech companies we know who's running these companies. We know the information that's being put out. And they're drowning out the good work that's here. So thank you for that, Lynette. Mavis, Vanessa, then Lawrence.
Hi, I have a question for Dr. Marcy about the role of insurance companies in sticking with race-based treatments. The scenario that I was familiar with is a woman's husband had prostate cancer. The doctor recommended a certain medication, but said insurance won't pay for it. because you are Black. And there was something about that the research didn't bear up for the Black community. And so she had to work around that insurance business. But anyway, you get the idea. Does insurance force you or force physicians to treat Black folks according to what they still believe?
So this is an example of using a group based outcome and applying it to an individual. And there are obvious problems with that because that we've discussed. What that situation requires is that the physician actually advocate for the patient by writing a letter saying, in our estimate, this person should be treated with this medication regardless of the socially identified race, and explain why. I'm not an expert in prostate cancer or its treatment, but I understand where that's coming. It's similar to the example of the high blood pressure and the use of diuretics first for Blacks because of a small difference in group outcomes related to just a continuum of variation among individuals. Yeah.
Right.
There are lots of complaints about insurance companies. and I remember it from my own experiences of you just had to advocate for your patients.
Yeah, I think this doctor did in this case, but the idea that it was too expensive for them to get the treatment because he was not a part of that data set and recommended for that medication by the insurance company. Yeah, crazy. Thank you.
Thank you. Thank you. Vanessa?
Thank you, Kamal. Oh, I'm on. Let me just check this. All right, we'll try this. No, I'm echoing. Sorry.
You're not here.
Why don't you give me the next person?
Oh no, it's not echoing from us though. You're crystal clear.
Yeah.
It's be on your side. Yeah.
Okay, so if you could see in the chat, I put a link to what was the Kenyan or Nigerian, I'm sorry, Nigerian medical student who decided to do medical illustrations that represented Black-skinned individuals. And I'll tell you, as a physician myself, when I saw this, I was like, holy crap, you're right. All of the medical illustrations, starting at Netter and everybody beyond, is all white. And so it's some things like that that you don't even realize are part of your training. That was amazing. But these illustrations, if you have a chance to take a look at it, there's something else. I have two other points. One is that it is truly exhausting in medicine to address all of the disparities and all of the biases and all of the prejudices. As a female physician, I mean, you're whacking with a machete every single day just to get treated with respect. And so there are definitely a list of things as far as race-based disparities and whatnot. And I was happy to see someone posted like what group is addressing the racism in medicine, because it's like, where is my backup on all of this? You know, there's so much about how women are dismissed, how, you know, there's so much, like, where's the backup? And so I did see in the chat, someone mentioned something about Boston University Black Women's Studies. So it's nice to know that there's something out there, but it is exhausting. There's so much, and it really becomes pick your battles. So, and the last thing I wanted to point out, you know, there's this theme I hear of people, and it is true, being dismissed for their concerns, having to dress up, you know, not being taken seriously. And one of the tips that I will die on this mountain about is I tell people, when you go into a physician, and if you have time, literally when you're going into the ER, grab a piece of paper and write it down. But what I say is organize your thoughts into bullet points of what we're going to talk about. And like, for example, I am concerned about like my blood pressure has been over 150 for 3 weeks, or this, or this. I mean, like concise bullet points, prioritized for your thing. And then here's the trick. I print it up, I take 2 copies. Because if I'm going to the doctor's office, I hand one to the medical assistant or the nurse. I say, this is what we're going to talk about today. And then the doc has a chance to be like, oh, this person's organized, this person's advocating for themselves. I understand their priorities going in, because sometimes frequently, physicians will go off on some tangent and you're like, wait a second, I have these 5 things I want to talk about. And so right off the gate, they're like, okay, there's these 5 things they want to talk about. So they kind of structure their mind, structure their brain, and you have a copy too, in case they lose their copy, you have a copy also. So everybody's on the same page when they walk in. And at the end of it, instead of them saying to me, do you have anything else? I say to them, or my family member or someone else says, do you have anything else? And so it's really a way of grabbing control of that physician-patient interaction. And I can't recommend that enough. I will die on this hill because I've seen it happen from all sides, physician, patient, family member, all the things. And it will help you like almost nothing else. I mean, it'll help you almost as much as having a physician family member right at your bedside. So that's something that is in your power to advocate for yourself. And it truly, having something on paper changes the way the physician interacts with you, because they can't ignore the paper.
No, thank you. Thank you. And I'll just say this as a Black person: if you have someone in your family that's adjacent to healthcare, having them on FaceTime or having them on a speakerphone, or if they can go with you too. And that, Vanessa, thank you for that paper idea with the bullet points. I mean, we have to it's life or death when we go in, and that's just the reality of it. And so I've watched the level of care rise to higher levels because someone was there who was healthcare adjacent, and I'm experiencing it personally. I have family members who have, and so yeah, thank you. I know our time is running out. We have Lawrence. And I will say this: if there are healthcare providers and professionals on this phone, at a long talk, that is one of the areas we've had the least traction is in healthcare. Every time, I mean, we've worked with Children's Hospital of Philadelphia. We've worked with Inova Healthcare Systems in Northern Virginia, in the Virginia area, and Yale School of Nursing. But outside of that, we have not had much interaction. And so if you have access to bringing these type of frank conversations or bringing a long talk, pick up the phone, do an email introduction. I know that there seems to be a barrier just to having this type of action and not just conversation, because we're an action-oriented community. Our formula is real simple: information plus information plus empathy equals action. And if healthcare is not somewhere that we need to have action in, then for my father's sake, who's been fighting since the 60s and 70s, help us out. All right, Lawrence, and then I know we'll close out. We should have one more hand here. Go ahead, Lawrence, and then Dr. Chambers.
Yeah, I just wanted to say real quick that back in the day, if you were not white, they would treat you to the point where, excuse me. All right, so if you ask questions about maybe your child, for a doctor, and you're inside, having this discussion, and you raise all of these questions, and if you're not white, they consider you to be arrogant. They consider you to be a problem, okay? To the point where they even note it into the child's medical record. So that if you go back, they'll know you got to be aware of this person.
Yeah.
Yeah. So, and I'm very grateful to the doctors today's doctors, because back in the day, you couldn't say anything, and the insurance companies were just as bad, because they probably got in touch with the doctor and said, oh, well, don't give him that, because that's too expensive. So these are the things that we've had to put up with in all these years.
Yeah.
I'm done.
Just a quickie. I put in the chat, tomorrow evening, I'm doing the 9th annual event on prostate cancer along with colleagues. So It's in there for those of you who want to learn more and see what the new treatments are and how we're dealing with Black and brown men to save their lives, because 2.5 million men are dying all the time from prostate cancer. So please join us tomorrow evening on Zoom. It's in the chat, www.admetech.com.
Thank you. Thank you. Thank you. I just want to thank I know we're over time, but 1 minute over time. I want to thank our community. This is what we are and who we are at A Long Talk. We're perfectly imperfect. We're a hodgepodge of do-gooders who just believe that we, the people, have the power to push back on what we're seeing take place on TV in real time, all across this country. And so it's up to us. So, Dr. Marcy, I don't know if you want to close out anything. I'm so grateful because from the moment I met you, you took time out to share. We've had open, honest dialogue, and I'm grateful that you put this talk together. But I'll pass it to you. But I do want to thank our community as well. But is there anything else you want to share? And I see Aaron, and Aaron, you all don't know there are invisible factors at work. None of this lunchtime speaker series would be possible. There's no way Kyle and I could do all this by ourselves. That's why we rely on our community. And we have one of our team members, family, friend. She's my sister. From another mother, Erin. I saw her hands. I didn't even know she was on here, but this wouldn't have happened without Erin. All the emails back and forth and correspondence and just logistic stuff. But yeah, Dr. Marcy, just anything you want to share as we're closing before we end the Zoom?
Thank you for those of you who shared your experiences and your wisdom. I'm glad that you had the opportunity to say that to this community.
Thank you. Thank you. Well, to be continued, we'll have more conversations coming up, and just look in your emails, and you all have a great rest of your day. And again, thank you to everyone for taking time out, and looking forward to seeing you next time. All right. Bye-bye.